have enough time to explore every aspect of monkeypox. Today, I am going to be touching on key features of the disease. Oh, apologize for that. Key features of the disease and the current outbreak. So first going to talk about, current situation, what is going on, and then I'm going to dive a little bit into what is monkeypox, the facts behind the disease. Then we're going to go through some information specific for cases and contacts when it comes to monkeypox, moving into vaccines for the illness, and then finally going to wrap up with some important public health subtopics. So first up, the current state of monkeypox. So the map on this slide shows the extent of the current monkeypox outbreak. As of September 16th, there were 61,282 confirmed cases that have been identified in 104 countries. Additionally, 20 deaths have been reported. Majority of the confirmed cases have had no established travel linkage to endemic countries that have a history of monkeypox. And as many of you have heard, many but not all cases have occurred in gay, bisexual, or other men who have sex with men, or MSM. Here in the United States, there's been a total of 23,499 monkeypox cases reported as of September 16th. And on August 30th, Texas reported the first death in a patient with monkeypox, though this patient was severely immunocompromised. The map on this slide goes through the cases for all 50 states plus Puerto Rico are one territory that has reported cases. So you can see at Virginia, we're kind of right in the middle ground in terms of cases. Diving a bit further into Virginia, here we have a total of 440 reported monkeypox cases as of September 19th. On the slide, you can see the epidemic curve for the state. We're seeing a plateau in cases here in Virginia. However, the data is incomplete for the most recent weeks, and you can see that as the gray portion on the graph. Once the data has been updated, we'll be able to better determine the progression of monkeypox in Virginia, as well as more accurately predict future case counts. Taking a bit closer look at the cases here in Virginia, about 95.9% or majority of cases have been in males and predominantly middle age group, so in that 20 to 49 years of age. Majority of our cases have reported race and ethnicity as Black, followed by white and Latino. Do want to point out that while majority of our cases do fall in those categories, we are seeing cases that are female in different age groups and identify with different race and ethnicities. So it's kind of widespread and can affect anyone here in Virginia. All right, so now that we kind of know what is going on, the current state of monkeypox, I want to dive a little bit into what is monkeypox, starting with the microbiology. Monkeypox belongs to the genus Orthopox virus. This genus also includes the variola virus, which causes smallpox, and the vaccinia virus, which is actually used in the smallpox vaccine. It's important to note that chickenpox or varicella does not belong to this genus of viruses. So that's a common misconception. So even though the name chickenpox has that pox, it does not belong to the same group. Monkeypox has two distinct clades, which were recently renamed by the World Health Organization in August. Clade 1 is the former Central Africa clade, and it causes more severe disease. Thankfully, this is not the clade circulating in our current outbreak. Rather, we're seeing cases that belong to clade 2 or the former West Africa clade. Historically, this clade has caused less severe disease, and it can actually be further divided into two subclades. So clade 2A and clade 2B. Clade 2B is what we are seeing in our current outbreak in majority of cases globally. Monkeypox was first discovered in 1958 when two outbreaks of a pox-like virus disease occurred in colonies of monkeys kept for research, which is where we got the name monkeypox from. Now for some key facts about the virus. First, despite the name monkeypox, because it was given to us from monkeys, the source of the disease remains unknown. Next, various animal species have been identified as susceptible to the monkeypox virus, so this does not just affect monkeys and humans. It can also affect rope squirrels, tree squirrels, Gambian pouched rats, and other non-human primates. And this is actually the reason why our monkeypox outbreak is of concern, because Here in North America, and definitely in Virginia for any local residents, we have a very large squirrel population. So there's fear of monkeypox entering our squirrel population since it has been known to affect other species of squirrels. So that's why it's of concern here in the United States. Um, Additionally, monkeypox in humans was first identified in 1970 in the Democratic Republic of the Congo in a 9-month-old boy in a region where smallpox had been eliminated. So, with the eradication of smallpox and further the cessation of smallpox vaccination, monkeypox has emerged as the most important orthopox virus for public health. If there were public health professionals who did not view monkeypox as important before this current outbreak, most certainly now their minds would have been changed. This map here shows the countries where monkeypox naturally occurs. One characteristic of the current outbreak, as I mentioned earlier, is we are seeing majority of cases in countries where monkeypox is not endemic, and these cases have no recent travel to these countries. So even though the virus is associated with Africa and countries in Africa, it has spread, and now we're seeing it across the world. Moving on to transmission of monkeypox, animal to human or zoonotic transmission can occur from direct contact with the blood, bodily fluids, or cutaneous or mucosal lesions of infected animals. As I mentioned a few slides back, the natural reservoir of monkeypox is not yet identified, though rodents are a most likely source. When it comes to human transmission, it can result from close contact with respiratory secretions, skin lesions of an infected person, or recently contaminated objects such as towels and bed sheets. Transmission via droplet respiratory particles usually requires prolonged face-to-face contact, and that's what puts our healthcare workers, household members, and other close contacts of cases at a greater risk. Additionally, transmission has been noted to occur via the placenta from mother to fetus or during close contact during or after birth. I do want to point out that while we know close physical contact is a risk factor for transmission, it is unclear if monkeypox can be transmitted specifically through sexual transmission routes. So that's kind of a myth going out there that monkeypox is an STI or transmitted sexually. That has not been proven. As of right now, it is purely close contact with the lesions or bodily fluids. Apologize, my slide is not changing. There we go. All right, so now switching gears a little bit to talk about clinical features. As public health professionals, we should have an idea of the clinical features. That way we can help identify it here in our community. So early symptoms of monkeypox include fever, headache, fatigue, and swollen lymph nodes. Swollen lymph nodes is actually kind of a key characteristic that we're seeing in a lot of our cases with this outbreak. The characteristic rash of monkeypox typically follows 1 to 3 days after the onset of these early symptoms. So the rash doesn't always appear first. And while the illness is self-limited, meaning most people can recover without medical treatment, it can last anywhere from 2 to 4 weeks, and the lesions can be very painful and itchy. So unlike COVID, where we saw that most people recover in that 10 to 14-day period, monkeypox can affect folks for much longer, up to a month. These folks are sick, they're in pain, and unfortunately have to remain home and out of work. There have been some atypical presentations noted among some cases in our current outbreak, including a localized rash. So traditionally, rashes appear all over the body, but a lot of our cases, we're seeing it just in a few spots. Additionally, lesions can be in the same body part, can be in different developmental stages. That's also unusual with this current outbreak. Additionally, public health professionals, it's important to note that part of diagnosis is differentiating between monkeypox and other potential diagnoses. So whether that involves other clinical evaluations, other testing that needs to be done, we can't just assume anyone that comes in with a rash is monkeypox, because there are other diseases out there that are affecting our communities. And before I move to the next slide, I do want to give a heads up. I've included some pictures of monkeypox lesions. So if you're sensitive to visuals, just take any precautions you may need for about the next 30 seconds to a minute. Monkeypox is known for its rash. That is one of the most common characteristics when it comes to this virus, and it's composed of well-circumscribed, firm, deep-seated lesions that often develop umbilication. And during the most recent outbreak, lesions have been occurring in the genital or anorectal regions, or even around the mouth or inside of these people's mouths. The rash does not always go across all parts of the body. Rather, as I mentioned, we've seen it in localized regions. So we've had cases where they've only had rashes on their arm or only on their back. So it doesn't have to cover the entire body. Another unique feature is traditionally with monkeypox, rashes appeared on the hands and soles of people's feet, but we're actually not seeing that in a lot of our cases here in Virginia with this current outbreak. So that's just another reason why this outbreak is appearing atypically compared to previous cases and outbreaks. This table goes through the monkeypox rash stages. I'm not going to go through all of them. You guys can read the screen. It's a lot of writing, a lot of dates involved, but I do want to point out that the entire process can take anywhere from 2 to 4 weeks, as I mentioned, and that a person is considered contagious until their scabs have fallen off the lesions and reveals new skin. So that's why it's such a wide range, that 2 to 4 weeks, because depending on the person, depending on how their skin recovers, any other medical conditions they have going on, it can take a really long time to complete the healing process. Last part of this section I want to go through are the case definitions that we're using in today's outbreak. So we have two main case definitions that we're using, confirmed and probable. A confirmed case can be met in one of two ways. First, it can be the demonstration of the presence of monkeypox virus DNA by PCR testing or next generation sequencing, or if monkeypox virus can be isolated from a culture. Probable cases have a bit of a looser definition. It's a case that has no suspicion of other recent orthopox virus exposure, such as being vaccinated with the ACAM 2000 vaccine that we'll talk about a little bit later, as well as it can meet one of the following criteria: orthopox virus DNA detection by PCR using immunohistochemical or electron microscopy testing methods, or demonstration of detectable levels of anti-orthopox IgM antibodies. So I know that's a lot of technical science terms when it comes to testing. So just to kind of recap it in a simpler, clear way, the main difference is a confirmed case has to have monkeypox virus DNA, while as a probable case only needs the orthopox virus DNA. So that's the main distinction between our confirmed and probable cases. All right, so now that we've got through all of the technical science information, we're going to get a bit more into the public health side of it, starting with discussing our cases and contacts and guidelines, treatment options, and all of that good stuff associated. So first thing I do want to start off with is case-specific information. If you or if someone thinks they have monkeypox, the first thing they should do is isolate. If you have symptoms, you should separate yourself from other people and pets, cover your lesions, and contact your healthcare provider. If you do not have a provider, you can reach out to your local health department and they'll be able to assist you. Please make sure you call ahead to any healthcare facility to let them know that you are concerned about monkeypox. This way the medical staff can take proper precautions to protect themselves and best serve you. After contacting your healthcare provider, the next steps usually involve getting screened for testing. This can range from asking about your symptoms, exposure history, travel history. We also ask about your history with chickenpox and shingles, so there's a lot of questions that go into it. And once we complete that screening process, that's when testing can be pursued. The information on the left is actually a screen grab that I got from a flyer that Virginia Department of Health or VDH staff provide to monkeypox cases. So we want to make sure that every person we talk to who's diagnosed with monkeypox has accurate information on hand. We email this flyer to folks, or we can either mail it to them, whichever they prefer. The flyer, though not pictured on the screen, contains links to resources both on local health districts page, our state page, as well as CDC resources. So we really wanted to make sure we provided everyone with the most up-to-date information so they know where to go. All right, so treating symptoms at home, it's kind of an intensive list. I won't go through all of it per se, but The main thing is you want to talk to your healthcare provider. So they're going to be the best ones for you in terms of determining what treatment plan is going to be best for you. Most people, as I mentioned earlier, recover without any sort of medication or treatment, but lesions can be painful. They could be itchy. They can scab over, and it can make people really uncomfortable. So we just wanted to provide some other options that don't require a prescription in order to help manage pain. So to relieve pain and itching, medicines such as ibuprofen, acetaminophen can help with reducing pain, swelling, and fever. Another one that I found interesting, a lot of folks have said taking warm oatmeal baths can actually reduce the itching and pain associated with their lesions. So that's an option if someone doesn't want to take medication. There are ways to go about it without needing it. Another big one, because a lot of our cases we're seeing mouth sores. So we recommend, rinsing your mouth with clean salt water multiple times a day. Mouthwash that is alcohol-free can also be used. Alcohol stings too much for them to use it. Another option is sucking on ice chips or ice pops and just making sure they stay dehydrated. Really anything to keep the lesions from swelling too much. All right, so now we're going to get into more standard treatment options. So while there's no specific approved treatment options in the United States for monkeypox, there are treatment options that may prove beneficial for people who are more likely to get severely ill, and they can be accessed through the federal government and local health departments under an expanded access investigational new drug or an EA-IND protocol. So a lot of paperwork involved. We have to let these people know, it's kind of experimental at this point. We're trying to see, we have some data that shows it can be beneficial, but it's up to the case really whether they want to pursue it. This table goes over the 4 treatment options that fall under that EA-IND protocol. The one that we are using here in Virginia and the most common treatment is TPOXX. So in order to receive TPOXX, a case must be evaluated by a healthcare provider, and the provider must agree that the case has a high risk of developing severe disease. So I want to emphasize that severe disease. So anyone who has monkeypox, unfortunately, does not qualify for treatment, or it's more so for those folks that have underlying health conditions such as HIV or other STIs where they have multiple things going on and they need that medication in order to reduce the pain. Again, if the case meets the criteria, we fill out piles of paperwork in order to get it approved for them, and then through the health department, we can get that treatment for them. I do want to point out that the CDC is currently developing an EA-IND to help facilitate the use of rimcidoforin. It's that last one that's italicized on the chart. So this one's not currently available, but it is going to be available. We're hoping here in the next few weeks. There's no word yet if Virginia is going to be using it, but again, another option that hopefully is going to be available for folks not only here in Virginia, but the United States and the world. All right, switching gears to the other side of monkeypox is we're going to get into close contacts. So when someone has monkeypox, one of our big questions that we're asking them during the investigation process is, who have you been around? Who have you potentially exposed? So as a reminder, monkeypox typically spreads through prolonged close skin-to-skin contact with a person who has monkeypox or their contaminated materials, so towels, bed sheets, clothing. Transmission during quick interactions between people in close proximity has not been reported for any persons with monkeypox, so we really are looking for that prolonged contact. For close contacts, the CDC has established a risk assessment process that divides contacts into 4 risk levels. Each risk level category is intended to highlight the need for monitoring and assist in determining the need for post-exposure prophylaxis. The purpose of risk exposure level is, they can be recategorized depending if they've been exposed more than once, if they develop, or we realize they're immunocompromised. So it's kind of ebbs and flows. So once you're in a category, you're not stuck. Speaking of those categories, so these are the 4 categories that the CDC has established for close contacts of monkeypox. So they're pretty standard of high, medium, low, and no risk. The main difference is between the top 2 and the bottom 2 has to do with our post-exposure prophylaxis, or on the screen it's abbreviated as PEP. So our high and medium folks, they're most likely going to be recommended to receive PEP, and I'll go into some more details about that in a few slides. Our bottom two exposures, low and no risk, they're most likely not going to be recommended for PEP. So that's the main difference. Additionally, if you're at no risk for developing monkeypox, we're not going to go forward with monitoring you for your monitoring period. When it comes to monkeypox, the monitoring period for close contacts is 21 days. So it's a really long incubation period from last exposure to symptom development. So that's why we really want to focus on these people that have a pretty decent chance of developing monkeypox. When it comes to monitoring, the health department, we have a survey that we send out to folks every day. It can come in the form of an email or text message. They fill out the survey of, this is the time I'm filling it out. These are the symptoms I'm having, or if I'm not having any symptoms, and that gets reported to the local health district where the person is a resident. This way we can follow up on them, make sure they're doing okay. And this way, the second they do develop symptoms, we can reach out to them and get them tested sooner rather than later. All right, regardless of risk group category, close contacts, as I mentioned, are to monitor health for 21 days to keep an eye out for symptoms. And depending on the risk group, here at the health department, on top of doing the survey, we may actually reach out to you in a phone call every single day. This is going to apply to our high risk exposure. So, intimate partners, household members, especially when there's children in the household, we really want to make sure they're doing okay. Also our healthcare workers, if they've been exposed in a healthcare setting, there's a higher risk of them developing symptoms as well. The picture on the right is a screen grab from the flyer that we give to close contacts. So again, we want to make sure we're providing them with the most up-to-date information so they can educate themselves and be aware of what they need to look out for. All right, moving now into vaccines. Currently, there are two vaccines that are available for monkeypox. Both are actually smallpox vaccines, but have been proven to be effective in preventing monkeypox. The first on the left-hand side is the Jynneos vaccine. It was first licensed in the United States in 2019 to prevent smallpox and monkeypox. It's administered by a subcutaneous injection in a 2-dose series. So similar to those COVID vaccines, you have to get 2 doses in order to be considered fully vaccinated. The 2 doses are separated by 4 weeks. So again, common theme, everything in monkeypox seems to take a little bit longer than it did with COVID. The Jynneos vaccine is currently recommended by the CDC for people age 18 and older who are at high risk for monkeypox illness. Switching gears to the right side of the page, our second vaccine is the ACAM2000 vaccine. This is actually a live Vaccinia virus, and it requires 1 dose, and it's administered using a droplet by the percutaneous route, and it involves 15 jabs of a bifurcated needle in order to administer the vaccine. Now, 2 vaccines, clearly, with most vaccines, there are risks and things that people need to be aware with both of them. So the Jynneos vaccine is a newer vaccine. However, the clinical trials have not indicated specific safety risk at this time. There's no visible take, and as a result, there's no risk of spreading the virus to other parts of the body or even to other people. As a vaccine administrator, I do not need to be vaccinated for monkeypox prior to administering the Jynneos vaccine. And the only risk that comes to folks is don't get this vaccine if you're allergic to any of the components of the vaccine. That's kind of the main thing we want to focus on. Now, switching gears to the ACAM2000. Unfortunately, this one has many precautions and risk for serious adverse effects associated with this vaccine. Infection control measures are required. Once a person becomes vaccinated with the ACAM2000, it's a live virus, so they actually will develop a lesion. So then contact with the vaccination site can result in auto-inoculation or infection tensors. So once people receive this vaccine, they have to be super cautious, make sure it's covered on their arm, because we don't want to spread the virus as we're trying to stop it with vaccination. So I do want to point out here in Virginia, we are only using the Jynneos vaccine. The ACAM2000 is being reserved in more of a crisis situation. This is just a quick note that on August 9th, the FDA issued an emergency use authorization for the Jynneos vaccine, which allowed it to be administered by the intradermal route instead of the standard subcutaneous route. This change increases the total number of available doses up to 5-fold. So this is a big change for us. However, I do want to make sure everyone's aware that it does not change how effective the vaccine is. So studies were done, they showed it was still effective. So that's all good news. And we have more doses now to give to everyone. Now, as far as BDH's vaccine strategy, we have a three-tier strategy, priority 1, 2, and 3. And the first group, our traditional PEP, is when we vaccinate individuals following known exposure to a case. So this happens with a lot of infectious diseases around the world. You've been exposed, but to get you to treatment. So it's a little different here with monkeypox is we have two other sub-tiers in terms of rolling out the vaccine to everyone. So our second tier is the expanded post-exposure prophylaxis. So this approach aims to reach people even if they have not have document exposure with someone. Like a really good example of this is if, let's say, there's a concert and we know that a case of monkeypox was in this concert, we may move forward with offering the vaccine to everyone who was at that concert because we know there was a case there. Not everyone would have been in contact with them, but better safe than sorry. Our third priority tier is our pre-exposure prophylaxis or PrEP. This is vaccination of those at a higher risk for monkeypox. So does not involve exposure. It does not involve being in a location with someone who has monkeypox. And this is where we are now in Virginia. So Virginia's guidelines are, these are the current groups of people eligible to receive the monkeypox vaccine. It's people of any sexual orientation or gender who have had anonymous or multiple sexual partners in the last 2 weeks, sex workers of any sexual orientation and gender, or staff of any sexual orientation or gender at establishments where sexual activity occurs. So again, we're in that phase 3 of we're widening the category of people who may have exposure, but it's not documented. We don't have any proof that a monkeypox case has been around them, but their activities put them at a greater risk of contracting it. And the goal is that when coupled with self-isolation and other prevention measures when symptoms first appear, that this expanded PEP may slow the spread of the disease in areas with larger numbers of monkeypox cases. That is the reason why we're taking this approach. This slide just goes over some brief vaccine data here in the state. As of September 19th, we've administered 9,390 first doses and 3,611 second doses. So our northern region obviously has the most vaccines administered based on the graph. Eastern, we're getting there. You know, we're amping up our vaccination strategies here, so we are going to be pushing out more moving forward. Where do I get the vaccine? So if you qualify to get the vaccine, you have a couple of options. We have a vaccine appointment scheduling engine. The link is included. You can call your local health department, or you can actually fill out the Virginia Monkeypox Vaccine Interest Form. So this slide shows pictures. The first is of that of vaccine appointment scheduling engine. So this engine, you can actually schedule both for monkeypox and COVID. So make sure you're selecting monkeypox. The bottom picture is of that interest form. So if you're interested in receiving the vaccine, you can fill out this form. Additionally, on this form, there's an option to where you can put in your reference code so you can actually see the status of where your interest form is, if someone's received it, if they're in the process of following up. So it's a good way for people to be able to monitor, you know, what is the health department doing? How are we following up with folks? All right, final component that I'm going to go over today are some important public health subtopics associated with the monkeypox outbreak. These topics are in no means a complete list, but they are important nonetheless. First, I want to go over behavior changes. So behaviors have changed during the current monkeypox outbreak. Published in a CDC MMWR, a study took place during August 5th through 15th, and it was completed by a convenience sample of 824 men who have sex with other men who responded to the annual American Men's Internet Survey. The study reported a 48% reduction in number of sex partners, a 50% reduction of one-time sexual encounters, and a 50% reduction of sex partners met on dating apps or at sex venues. These findings suggest that MSM are taking actions to reduce risk in themselves and their partners during the outbreak. Another important topic, and in my opinion, one of the most important topics as a public health professional, is health equity. The monkeypox outbreak has disproportionately affected gay, bisexual, and other MSM community members, as well as people of color. It's absolutely critical to ensure equity in both treatment and vaccination. Recent publications and available data suggest racial and ethnic disparities in vaccination rates, especially among Black and Latino men. This can actually be seen in Virginia's data, unfortunately. The previous slide showed that while majority of our cases are in Black men, the largest percentage of folks vaccinated are white men here in Virginia. So that's something we need to do better in terms of our vaccine rollout. So how do we ensure health equity in our vaccination plan? So there are steps that we are taking and what we can do to help improve our health equity when it comes to vaccination. A couple key ones I want to point out, the first one being engaging people from affected communities and planning the vaccine programs as trusted sources of information about both monkeypox and vaccination. As public health professionals, sometimes we get stuck operating in our own bubble. We have to outsource and involve community members in these decisions because other community members are going to look to their community leaders for guidance and advice. So if we incorporate our community in that way, it's going to be a more effective process. Another one on this slide I want to point out is providing plain language details about all available vaccination options, and the main part being in the preferred language of the individual. Unfortunately, sometimes the public health information is pushed out really quick in English, but there are communities where majority of people don't speak English, whether it's a Spanish-speaking population or any other language. So we need to make sure we're doing a good job of pushing out information in the language of the community so they know, one, we know them, we understand them and their culture, but two, so they can be educated about what's going on. These are a couple other steps in order to ensure health equity with our vaccination plans. One big one here I want to point out is the use of multiple channels such as social media, websites, TV, radio announcements, and flyers. So the more sources you put out there, the more people in a population you're going to touch. Our younger population, they're going to be around the social media, the websites, the more internet-based options, whereas older folks, they might be listening to the TV or radio more often. So as public health professionals, if we cover all of our bases, we're going to reach everyone in our population. One last subtopic I want to mention is risk communication. Anyone can get and can spread monkeypox. So while it's in a certain population currently, we all know that contagious diseases do not stay in one population as we saw with COVID. So we want to make sure we're really putting the information out there that it's important for the entire population to know the symptoms of monkeypox, the behaviors that can lead to the spread of monkeypox, because if we only educate a certain portion of our population, they'll be ready to go, but we're excluding countless others that are going to be at a greater risk just from not knowing. As public health professionals, we can combat stigma by providing fact-based information and emphasizing that monkeypox is a public health concern for everyone. So my last slide is, what is VDH doing? So what is our state health department doing? We are investigating all reported cases of monkeypox, and we're facilitating testing at BCLS, which is our central laboratory. We're communicating with our healthcare providers and asking them to report suspected cases to us before testing has been done, or if testing has been done, we want to be ready to go if that result does come back positive. When cases are detected, we reach out to them. We check in. How are you doing? What's going on? We collect close contact information and we monitor cases and close contacts. And we also monitor people who may not be Virginia residents. If we have a member of our military who's stationed here, we're going to monitor and make sure they're okay. If there's an international traveler, but they're here with monkeypox, we're still going to make sure they have someone they can reach out to who's going to help them through this process. This slide has a bunch of really good resources for further reading. If you're interested in it, want more information, highly recommend all of these sources. And just want to say thank you for inviting me here today. My email is on the slide. If anyone has future questions, please do not hesitate to reach out. I would be more than happy to talk with anyone. So that is it on my part. So I'm going to hand it back to you, Amy.
Thank you. And again, we appreciate you being here and talking with us. We also have Dr. Little here today. She is the Director of Student Health Services, and she's going to give us a little bit of information that might be more specific to campus and our Monarch community. So thank you for being here with us today.
You're welcome. And thank you and Erica for having us and for inviting us. We're so glad to be here. And Dr. Wadicus and Miss Chrissy Mente, I know we had an urgent matter to come in, so I don't think they're on the call, but we also have our nurse practitioner and our LPN, Miss Cassandra Ewing and Angela Hector, and also Miss Julia Coots, I believe, is here. And also we have Miss Chantel Matthews. So I want to make sure that our team and C's team is recognized for being here. So we actually developed a task force similar to the COVID task force, individuals that are serving to help put our response plan together. And on our website, and I can share the screen if you would like, before we end, so that everyone can see where the resources are listed. But our team consists of course, our student engagement and enrollment services, our housing and residence life, also risk management, also our emergency management team, and those that are in the Aramark, Dining Hall, ODU Police, Auxiliary Services, Environmental Health, and Academic Services, as well as IT. So just to let you know who's a part of our task force, and I'm calling us a task force. This is an unofficial name, but we are definitely the same members that responded to COVID. And the university has the ability to test for monkeypox. Jacqueline did a great job with going over the slides. Awesome. It was awesome. And I'm almost ashamed to have to follow her. But I want everyone to know our plan and our response, that we do have a plan. Of course, as Jacqueline mentioned, it is a long period of isolation. And one piece that we want to make sure is that the mental health of our individuals who may be diagnosed is addressed. And Dr. Himmel is our counseling services director, and she is excellent. She's here, and she has some resources that I could share with you as well if you want to send out to the attendees that will offer some support from the mental health aspect. Because when you think about 21 days of isolation, that's very it is very severe and can be, threatening to someone's mental health. So we want to make sure that our students know that there are services available through counseling services. So as Jacqueline said, there's a 21-day period. Some of the information that we have and want students to know is that we can provide ibuprofen, Tylenol, bandages, antibiotic ointment, things that may be needed during the course of the 21-day cycle. Also, we are available for telehealth appointments. We have a screening form that we put into place if someone thinks that they have monkeypox. We have that in place, and it is on our Monarch Wellness portal. So if students go onto the portal, they can see that. We want to make sure also that we develop programming that decreases stigma associated with monkeypox. And Miss Chantel Matthews again is here, and she's great with putting programming together. And we are planning a program for monkeypox, and that would be also in conjunction with our accessibility office, but we wanted to kind of gear it toward topics that we thought were of need, because a lot of times students want to know about sexually transmitted disease infections and testing at the same time. So, and monkeypox is not a sexually transmitted disease, but when we speak about safe contact, whether it be skin to skin, we also, need to address sexually transmitted infections. And so we are purposefully putting that together. As we started the new school year, we've been, again, thinking about how we can best bring all of our partners together, and would love to partner with the Public Health Student Association if that's something you all would like to do. So we have, again, the counseling support. We have cleaning and disinfecting if that's something that's needed. If there, were a case, then of course we would have that response, because the cleaning piece is important. Cleaning with the EPA registered disinfectant. Also, handling of laundry is important. That should be handled with gloves. If someone needs gloves, and yes, we will. We can help provide those as well, and we have them because we've had that through COVID. One piece is providing support for students who may have roommates. It is recommended that the student, that if someone tests positive, that they go home, because it's 21 days. And that's a long time to be isolated in an isolation area on the campus. So we do encourage, that's a part of our plan, is that the student will go home, rest and recover in an environment that is supportive with family. We're supportive here, but of course in your home environment, you have that family support. And then if that's not an option, then our team is here to work with you through housing, through student outreach and support. And also student outreach and support is available for establishing notifications for faculty. So if there's someone who has to be out of class and may need online learning alternative, student outreach and support is there for that piece, for the academic area. And again, we have little flu packs that kind of work along with all of the viruses we've seen, as well as the flu. So some of the same items that we've already had in there, we have those ready to go if someone needs that, or if they think they, have any kind of viral illness, whether it be flu, again, the COVID or monkeypox, or any other matters that come to hand. And I think our local pharmacy here is a CVS pharmacy. And again, we're, available to work with students to help them navigate that piece, as well as the dining piece, because right now, Aramark has a 6-student plan. And right now with monkeypox, some of the signs and symptoms we see are not as vicious as the GI symptoms that we see with COVID or the flu. But again, working with Aramark and the student to get them access to food is something else that we can assist with.
Well, thank you. Does anybody have any questions that maybe one of these lovely women can answer for you? And if not, I want to say thank you again to both of you for coming. And Jackie, that was a great real world experience, kind of seeing how epidemiology is working with public health in the real world right now. So for all the public health students, that's actually really great to see how that works. And especially the improving equity component, because I know that is a huge part of public health. And we fail a lot. Let's be honest. In the United States, we fail to be as equitable as maybe we should. And for everyone who's here, I'm going to create an email with all of the links that were mentioned by Dr. Little and Jackie. We are going to try to have this available on YouTube for anyone who wasn't here. So everyone in the PHSA will get that link also. But again, are there any questions? Does anybody have any concerns that they want to discuss or ask about? And if you don't want to talk, you can put it in the chat.
I see Erica put about the oatmeal baths. Yes. Remember taking oatmeal bath as well. Very soothing. Yes.
Yeah, temporary relief, but
Yes.
as far as the resources that you mentioned, Dr. Little, are those things that are available specifically at student health? So any of like the care packs, and if people need like antibiotic ointments, so that's the one location that those would be located.
Yes, and I hear that what you're saying. We work very closely with housing and residence life, and even with COVID, sometimes we would have some things in a designated area for housing to access when we had our isolation quarantine area. But right now, our plan for COVID is isolating in place, or if someone's not comfortable, then they go home. So yes, they're here, but we're on call, like our staff are on call after hours. If someone needs something, we can make sure that we, provide a resource on how to get that, because some pharmacies, we can get them delivered, or sometimes we use a buddy system to help students, to get what they need.
Hey, Dr. Little, this is Ray. I have a question. Do we have a capability in school for quarantine, such as COVID or any monkeypox? For example, they contacted it directly in the class, and the person, has reported and cannot go home for some reason.
We have resources if there's a plan where a student cannot go home.
Thank you.
You're welcome.
And I guess following up on that, is there a way of notifying, I guess, if it was like a classroom, a student was in class with other people, of notifying people they might have been in close contact with for monkeypox?
So that's where the Norfolk Public Health Department and Jackie's area people that do the epidemiology and the contact tracing, that's where they come in, and they will be notified, and they actually do the contact tracing and determine what needs to be done next steps. And we do have EPA disinfectant with electrostatic cleaning if there are areas identified that need to be cleaned in the academic area as well as the residential area. But Ray, to answer your question, you asked about isolation quarantine. The plan is isolation in place for COVID. And because of the time frame of isolation for monkeypox, we do encourage students to go home, because sometimes, it, again, with the mental health aspect of it, it can be, offer a long period of time of isolation and feelings of anxiety and stress.
Copy. Thank you, Professor. I have a question for Jackie. For example, a person reported that they might think that they are exposed to monkeypox, but there's no symptoms. Can it be transferred without any lesions or any symptoms of monkeypox?
Just to make sure I'm understanding your question fully, are you saying that the person who thinks they were exposed is not having any symptoms, or the person who exposed them wasn't having any symptoms?
For example, I reported that I think I'm exposed, but the person who I think I'm exposed to doesn't have any symptoms of monkeypox.
Okay, so how we would handle that situation then is we would provide the person information, most likely for the low or no risk category when it comes to close contacts. Unfortunately, we cannot reach out to the person who quote unquote has monkeypox unless we get an official lab report or case report for them. So we can't call and say, hey, so-and-so said you might have monkeypox, what's going on, So we have to treat the person as maybe some exposure, but we also would walk them through possible other diagnoses that person may have, talk to them. Do they have, what kind of symptoms are they having? Or if they don't have symptoms, encouraging them to go to a medical provider, because there could be something else going on. Most monkeypox, and I'll say here in Portsmouth and I believe in Eastern region, all of them have had a rash. So that's kind of the main thing. If someone's not having it, it's most likely something else.
Copy. Thank you so much.
And I know there had been some talk on the news, I forgot which news station I was listening to at the time, that the monkeypox virus is mutating. And I know it's not going to mutate nearly as fast as COVID, or at least it doesn't seem to be at this point. Is there any concern that maybe we're going to start seeing different presentations, or that it's going to affect virulence or anything like that?
Sure. I think there's always a concern when it comes to any infectious agent that it's going to mutate in a way that is going to negate some of our public health efforts. As of right now, cases are plateauing not only here in Virginia and the United States. We are still hopeful that we'll be able to get a handle on it before any negative mutations come our way. In terms of hearing news about it, I know VH is not concerned of it right now, but it's always something in the back of their minds of, okay, if this were to happen, how do we respond? Thankfully, we have 2 vaccines for this already, so maybe one seems to be more effective against the mutations than the other. But also, additionally, it's not like COVID where we have to start from scratch when it comes to creating a vaccine. So I know COVID, they just approved the Omicron specific vaccine, so there's a potential for monkeypox to become specific to whatever variant is out currently in the community. So we're not starting from ground zero, thankfully, so it should be a little faster, but definitely something in the back of all of our minds.
And again, I want to say thank you for everyone for coming. Thank you, Dr. Little and Jackie, for presenting with us today. We really appreciate all the work that you're doing with our community. And again, just for showing up and giving us all this great information. If there are no other questions, I'm going to say goodbye to everyone, and I hope you learned something exciting and new today.
Thank you.
Thank you.
Thank you.